Neurology quiz number 108. Discuss medications and other measures used for prophylactic treatment of migraine, part 2 of 2. The second group of prophylactic medications in migraine includes migraine-specific medications. Number 1 is CGRP antagonists. These can be monoclonal antibodies such as erenumab, fremanezumab, galcanezumab, and eptinezumab, or they can be small molecules or gepants such as atogepant and rimegepant. Number 2, on a botulinum toxin A. Number 3, triptans used for short-term prevention of menstrually related migraine, such as robotriptan, naratriptan, and zolmitriptan, and neuromodulation devices. Migraine-specific medications, CGRP-targeted migraine preventive medications, monoclonal antibodies. Of the CGRP monoclonal antibodies, eptinezumab, fremanezumab, and galcanezumab target the ligand, while erenumab acts at the receptor. Erenumab, fremanezumab, and galcanezumab are administered as subcutaneous injections using autoinjectors. Eptinezumab is administered by IV infusion. It is most commonly given at an infusion center and is also available as a 30-minute in-office IV infusion. The efficacy of CGRP monoclonal antibodies for the preventive treatment of migraine has been evaluated in at least 25 randomized clinical trials. Multiple trials have established the efficacy of monoclonal antibodies in episodic and chronic migraine. In general, the efficacy benefits of subcutaneous monoclonal antibodies become significant within the first week following administration. Incremental benefits often accumulate with repeated doses. Gepants. Rimegepant. This has regulatory approval and evidence for efficacy for episodic migraine. It is indicated for abortive treatment and prevention of episodic migraine. It has not received regulatory approval for the prevention of chronic migraine. Atogepant. This is the only orally administered CGRP targeted drug with established efficacy and regulatory approval for the preventive treatment of adults with either episodic or chronic migraine. Previously, CGRP targeted treatments were offered to patients who had an insufficient response to 2 or more non-specific oral preventives. In May 2024, the American Headache Society published a position statement update regarding the CGRP targeted treatments. It recommended that CGRP targeted therapy should be considered as a first-line approach for migraine prophylaxis, along with previous first-line treatment, without any requirement for prior failure of other classes of preventive treatment. This was based on the evidence for efficacy and tolerability as well as safety of CGRP targeting migraine therapies, which was shown to exceed that for any other preventive treatment approach. Data from trials has been corroborated by extensive real-world experience. This slide shows the indications, route of administration, time to maximum plasma concentration, and half-life of the large molecular weight monoclonal antibodies and the small molecular weight gepants. This slide shows the dosing schedule for the anti-CGRP monoclonal antibodies. This slide shows the dosing schedule for the gepants. The CGRP monoclonal antibodies and the gepants are generally well tolerated. These agents are not recommended for use during pregnancy. In clinical trials, the most commonly reported adverse events with the CGRP monoclonal antibodies are constipation and injection site reactions. With atogepant, the most common adverse events were constipation and nausea, and some adverse events such as fatigue and anxiety were dose-dependent. In rimegepant trials, adverse events that affected at least 2% of patients were nasopharyngitis, nausea, urinary tract infection, and upper respiratory tract infection. There is limited data comparing CRGP targeted treatments to non-specific oral agents. A comparative study between topiramate and erenumab showed that erenumab had greater efficacy and better tolerability than topiramate. In terms of medication selection, patients may often prefer the oral option, but some patients prefer monthly injections or IV injections every 3 months. Erenumab is most likely to be associated with constipation, and other agents may be preferred in constipation-prone patients. There are also reports that may be associated with hypertension, and blood pressure may need to be monitored. No additional risk of adverse events has been reported when combining anti-CGRP medications for prophylaxis and abortive treatment, for example, combinations of monoclonal antibodies and rimegepant. Although the anti-CGRP monoclonal antibodies may have rapid onset of action, an adequate trial of 3 to 6 months should be given in patients who do not respond initially. When treatment with such agents is successful, a pause may be possible after 12 to 18 months of continuous treatment. For the anti-CGRP monoclonal antibodies, switching between antibody classes, that is ligand versus receptor, can be beneficial in some patients. In practice, combining a CGRP targeted treatment with non-specific oral agents is common, and CGRP targeted therapies can be added to partially effective non-specific oral drugs. Treatment with CGRP monoclonal antibodies, GPANs, on a botulinum toxin A, and neuromodulation devices, as well as natural supplements, can be started at the optimal dose. Unlike non-specific preventive medication, dose escalation is not required, and this reduces the delay in the onset of benefit. On a botulinum toxin A, this is FDA approved for chronic migraine only and has level A evidence for prevention of chronic migraine. However, in practice, it is also used in patients with episodic migraine who have not responded to non-specific or specific migraine prophylactic agents. Comparison data for botulinum toxin A and CGRP monoclonal antibodies in the treatment of chronic migraine is lacking. Treatment choice depends upon provider and patient preference, as well as insurance coverage. Many headache specialists use the two treatments in combination. Neuromodulation. Several neuromodulatory devices have been approved for preventive treatment of migraine. Options include supraorbital transcutaneous nerve stimulation, non-invasive VNS, single pulse transcranial magnetic stimulation, and remote electrical neuromodulation, among others. These devices have favorable safety profiles and are indicated in patients who cannot take or prefer to avoid preventive medications. They are often used in pregnancy. However, insurance coverage is often difficult to obtain, and this limits their use. For a detailed discussion on neuromodulation, see quiz number 79. Preventive treatment of chronic migraine. Few treatments are specifically FDA approved for chronic migraine prevention, but several oral treatments have been studied. Topiramate has high level of efficacy, while amitriptyline, gabapentin, sodium valproate, and tizanidine have shown benefit in small trials. Botulinum toxin A is FDA approved only for chronic migraine. The CGRP monoclonal antibodies and the GPANT atogepant are FDA approved for migraine regardless of frequency and are good options in this patient population. Migraine prophylaxis during pregnancy. For a detailed discussion of this topic, see quiz number 54. These are guidelines for treatment of episodic migraine with or without aura, published by the American Headache Society in 2024 in the journal Headache. As can be seen from the list, anti-CGRP treatments are now considered as first-line treatments and no longer require failure of non-specific oral medications for use. These are guidelines for treatment of chronic migraine with or without aura, published by the American Headache Society in the same journal in 2024.